Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Yasmin Jordan, Associate Professor of Dermatology and Venereology, currently working at the Abdin Baristotropical Hospital, Dhaka. On behalf of the Psoriasis Awareness Club, I, as a Scientific Secretary, welcome you all to today's scientific webinar named Biologics in Psoriasis Treatment, Bangladesh Perspective. Indeed, a challenging and hot topic for the daily practitioners. This webinar is kindly sponsored with the technical support from Unimed UniHealth. Psoriasis Awareness Club, established in October 2017 with the motto of serving patients with psoriasis and patients with psoriatic arthritis and contributing to the improvement of the overall health of their personal and social life. Another purpose of this club is to keep the local dermatologists updated about the current issues and advancements in the field of psoriasis. Now about biologics, biologic refers to protein molecules derived from living sources and used in various diseases to target specific points in the inflammatory cascade of a particular disease rather than the whole inflammatory process of a disease spectrum like a drugs do. That's why the point which it differs from the drugs and biologic. Popularly, rheumatoid arthritis and ankylosing spondylitis, Crohn's disease, etc. are treated with biologics. In our dermatology, psoriasis, psoriatic arthritis, atopic dermatitis, some blistering diseases, hidradenitis suppurativa, and other some main sectors where biologics have already been introduced. And I think yet a lot to come in future. Now, in today's webinar, let's see whom we have with us today. As a chairperson and panel of experts, they all are the bright stars in their own field. It's my pleasure to introduce first, as a today's chairperson, Professor Dr. Mohammad Samuel Haq Sir, the founder of the Psoriasis Awareness Club. This club is indeed your dream child, sir. His selfless dedication has raised this club to this level what we are enjoying today. As a panel of experts, it's my honor to announce the name of Professor M.U. Kobi Choudhury, sir, ex-principal MH Samarita Medical College Hospital and Chief Consultant of National Skin Center. Sir is the recipient of prestigious Ekushe Podo, Independence Day Award, Tagore Peace Award, and many more to be mentioned. We, the present and past dermatologists of our country, we always owe to you, sir, for being such a visionary and adding a different dimension in the field of dermatology in Bangladesh. He is an honorable member of the Advisory Committee of Psoriasis Awareness Club. Welcome you, sir.
Thank you.
We have another panel expert, the renowned physician, Professor Brigadier General retired Dr. Mohammad Abdul Latif Khan, sir, the ex-head of the Department of Dermatology and Venereology of the Armed Forces Medical College and Dhaka CMH. A very sound clinician and reputed academician as well. Welcome you, sir. Next, it is my honor to announce the name of Professor Dr. Rashid Mahmood Khan, sir, the head of the Department of Dermatology and Venereology, Dhaka Medical College, Vice President of Psoriasis Awareness Club, and my direct teacher during my post-graduation. A teacher, a clinician, and I believe one of the most finest dermatosurgeon in our country. He is worthily carrying the legacy of his father, late Professor Dr. Hassan Mahmood Khan, sir, a pioneer dermatologist in the history of Bangladesh. Now, about today's speaker, Shamim Bhai, Associate Professor Dr. Shakar Mahbub Ahmed Shamim, MBBS, FCPS, MCPS, Diploma in Dermatology, Glasgow, Diploma in Aesthetic Medicine, USA, American Board Certified Dermatologist, and one of the founder member of the Executive Committee of Psoriasis Awareness Club. He is Chief Consultant of Dhaka Dermatology Institute, Vice President of SARCE AD, and currently working as Associate Professor in the Department of Dermatology and Venereology, AMH Samarita Medical College, Dhaka. He is truly an iconic figure in the field of aesthetic dermatology at home and abroad. But apart from his aesthetic expertise, today we would see through his upcoming presentation his in-depth involvement in the critical issues of general dermatology as well. So that's it. And during the session, dear participants, you all are encouraged and invited to drop your questions in the chat box. Now, I would request the chairperson, Professor Dr. Samuel Haq, sir, to inaugurate this webinar. Here you are, sir.
Assalamu alaikum. Welcome you all to this scientific session. আমার মনে হয় বাংলাতে একটু বলি তাহলে একটু জিনিসটা ভালো হয় এখন। সোরিয়াসিস অ্যাওয়ারনেস ক্লাব আমরা শুরু করেছি 2017-তে এবং আজ অবধি আমরা যতগুলি অনুষ্ঠান করেছি মেইনলি আমরা অ্যাওয়ারনেসের উপরেই কাজ করেছি এবং শুধু অ্যাওয়ারনেস শুধু পেশেন্টের জন্য না, অ্যাওয়ারনেস এবং বিভিন্ন সায়েন্টিফিক প্রোগ্রাম করেছি ডক্টরদের জন্য যাতে আমাদের নলেজগুলি আপডেটেড থাকে। টাইম টু টাইম আমরা বিভিন্ন রকমের প্রোগ্রাম করেছি এবং আমরা আপডেটেড রাখতে চেষ্টা করছি। বেশ কিছুদিন গ্যাপ ছিল, এনিওয়ে উই হ্যাভ ওভারকাম দ্যাট। এখন থেকে আমরা আবার রেগুলার মেইনটেইন করার চেষ্টা করব। আজকে যে টপিকটা নিয়ে আমরা আলোচনা করব ইজ এ বার্নিং ইস্যু। যদি গত 20 বছর থেকে সোরিয়াসিস পেশেন্টদের জন্য এই বায়োলজিক্স ড্রাগটা যে রেভলিউশন তৈরি করে নিয়ে এসেছে, আমরা এখন পর্যন্ত আমাদের দেশে সেটা সুফলটা পাচ্ছি না। কেন পাচ্ছি না? কস্ট ডেফিনেটলি আছে, কিন্তু আমরা অনেকভাবেই এটাকে পিছিয়ে যাচ্ছি। আমাদের পাশের দেশ বলেন, ওরাও তো অনেকটা অ্যাডভান্স হয়ে গেছে বায়োলজিক্স ইউজে, কিন্তু আমরা পারছি না। আমাদের নলেজটা হয়তো বা সীমিত, আমরা হয়তো বা পারছি না। কেন পারছি না? আমরা আজকে আমাদের বিজ্ঞ প্যানেলিস্টদের কাছ থেকে জানতে চাইবো। আমাদের সাথে প্যানেলিস্টের ভিতরে আছে প্রফেসর এমইউ কবির চৌধুরী, উনি এক্স প্রিন্সিপাল সমরিত মেডিকেল কলেজে ছিলেন এবং চিফ কনসালটেন্ট ন্যাশনাল স্কিন সেন্টারে। উনি বাংলাদেশের ডার্মাটোলজিতে একজন আইকন বলা যায়। আমাদের সাথে আছে ব্রিগেডিয়ার লতিফ, উনি সিএমএইচ এর এক্স চিফ ছিলেন ডার্মাটোলজি ডিপার্টমেন্টে। আমাদের সাথে আছে প্রফেসর রাশেদ খান, উনি ঢাকা মেডিকেল কলেজে ডার্মাটোলজির প্রফেসর এবং এনারা প্রত্যেকেই কম বেশি ডার্মাটোলজি ডিপার্টমেন্টে কাজ করছেন এবং বায়োলজিক্স নিয়ে কাজ করছেন। অল্প পরিসরে যাও বা আমরা কাজ করছি, আমাদের তবুও আমরা চেষ্টা করছি যে বায়োলজিক্সটাকে আমরা প্রতিষ্ঠিত করার জন্য। কস্ট তো অনেকভাবেই আমরা, অনেক ড্রাগেরই তো অনেক কস্ট থাকে, তাই বলে তো আমরা পিছিয়ে থাকতে পারি না। আমাদের আপডেট রাখতে হবে এবং ওয়ার্ল্ডের সাথে আমাদেরকে নিয়ে চলতে হবে। আমাদের যেখানে পেশেন্টের কোয়ালিটি অফ লাইফ নিয়ে প্রশ্ন আসে, তখন অবশ্যই আমাদের চিন্তা করতে হবে যে কিভাবে পেশেন্টকে ভালো রাখা যায়, কিভাবে পেশেন্ট সোরিয়াসিস ফ্রি থাকা যায় এবং তাদের লাইফটা, তাদের পরিবেশটা কিভাবে ভালো থাকা যায়, আমাদের সেই জিনিসটাই আগে চিন্তা করতে হবে। যাই হোক, আজকে আমাদের যে স্পিকার একাধারে প্রফেসর ডক্টর শামীম সর্দার শামীম, সে ডার্মাটোলজিতে একজন খুব নামকরা ডাক্তার। সে একদিকে যেমন কসমেটোলজি, একদিকে যেমন অ্যাস্থেটোলজি, একদিকে যেমন ডার্মাটোলজি, সব ফিল্ডেই তার একটা অগাধ বিচরণ। আমি আশা করি ওনার খুব ভালো উনি অভিজ্ঞতা দিয়ে আজকে লেকচারটা তৈরি করেছেন এবং বাংলাদেশের প্রেক্ষাপটে কি করা উচিত, কিভাবে আমরা এগিয়ে যাব, এই নিয়ে উনি আলোচনা করবেন। আমরা মনে হয় আমরা আর সময় নষ্ট না করে আমরা অনুষ্ঠানটা শুরু করি।
Thank you, Samuel Haq sir, today's chairperson, and thank you, Yasmin Juardar, for your kind note about me. In presence of the panel of experts, eminent dermatologist, Shadhinata Purushkar Prapto, my mentor, Professor M.E. Kobir Chaudhary sir, one of the another renowned dermatologist, Professor Brigadier Abdul Latif Khan sir, ex-head CMH, and the most smart and dynamic dermatologist in this country, Professor Rashid Mahmood Khan sir, as a panelist. So welcome you all. So today I will be speaking about biologics, treatment in psoriasis in Bangladesh perspective. I know today's topic will bring a lot of questions. I will try to answer all of the questions, and today's panelists, they will surely answer and give valuable suggestion in this regard. So I'm going to my presentation. There's a disclaimer. The information provided in this presentation are for the general information purposes only. No financial involvement with any of the manufacturers. We all know about psoriasis, so I want to skip all these things. So what is psoriasis, classification, psoriasis, treatment, all these things, I want to skip all these things. We all know psoriasis is a common and chronic recurrent inflammatory disease of the skin characterized by circumscribed erythematous dry scaling plaques of various sizes, usually covered by silvery white lamellar scales. So what are the comorbid conditions associated with the psoriasis? Very important topics. You have to understand all these things because the comorbid conditions are like the cardiovascular disease, metabolic syndrome, malignancies, anxiety, depressions, autoimmune disease. So is it aggravated with the biologic treatment? That is a burning question. So I will discuss with this thing, is comorbid conditions associated with the psoriasis is exacerbate or worsen with the biologics or not. So pathophysiology of psoriasis, we all know it. Mainly, I want to concentrate on the inflammatory part of the pathogenesis. We have other part of the pathogenesis, mostly the inflammatory part. Inflammatory part, there is, you all know that there are a lot of cytokines and interleukins all are secreted from the phagocytic cells or monocytic cells and directly presented to the antigen presenting cells, and it is trafficked to the inflammatory site, and lot of things, lot of inflammatory cascades are created there. So all we know that we'll discuss later on this regard. So important thing is how psoriasis affects daily on the social life. That is called the low self-confidence, embarrassment, why they need to expose their bodies, anxiety and depression, loss of productivity, absence from work, financial burden due to the prolonged treatment, social stigma, if others perceive as a contagious, psoriasis of palms and sole and psoriatic arthritis causes pain and physical disability, suicidal tendency. So daily quality of life is very important for every psoriatic patient. So assessment and classification of psoriatic disease severity, PASI scores, BSA, we have to know DLQ, right? If we classify with the severity, we can see mild disease is less than 3% body surface area, moderate disease is 3 to 7% body surface area, severe disease is more than 10% body surface area. PASI and DLQ is like mild disease is body surface area less than 10, PASI less than 10, DLQ less than 10. Moderate to severe, BSA more than 10, PASI 10, and DLQ more than 10. So we will know all the what is body surface area. PASI also, I believe everyone knows what is PASI, what is DLQ. I want to skip, and all of you know the management algorithm. The point which is indicated by Professor Samuel Haq that we are using all of the options for the treatment of the psoriasis, but why biologics not yet used? It's not correct. Biologics already used in dermatology field. We use a lot. I have treated with multiple patients, multiple sessions, and we are actually doing a research on Bangladesh perspective, which psoriasis acts on our skin type or all these things. So all we know the treatment algorithm like psoriasis and systemic treatment, daily treatment, phototherapy, topical, and others. So necessity is the mother of invention, and the new clinical situations where the conventional treatment options fail and are contraindicated, newer drugs are being developed, and the already existing ones are being tried as a hope rather than an exception. Results are giving rise to research, eventually handling in clinicians a new set of arsenals. That means biologics comes in this aspect. So what is biologics? I will try to make you understand what is biologics in a very simple manner. That is very important. Biologics are the wide range of substances that are produced from the living organisms. That's why it is called the biologics, or the certain component of the living organisms. Biologics are the protein molecules used therapeutically to target specific points into the inflammatory cascade of the various immune-mediated diseases. So what are the products we can call biologics? Like we can call serums, biologicals, vaccines, toxin, antitoxin, blood and blood components, allergic products, somatic cells, gene therapy, tissue and recombinant therapeutic proteins to prevent, treat, or cure the disease. History of biologics. First documented uses of the term biologics was in 1912. The isolation of the first ever biologics for the insulin in 1921. The second biologics was the erythropoietin, then vitamin D, estrone, androsterone, ascorbic acid, progesterone, all from 1934. The first monoclonal antibody approved by the FDA is in 1986 was the Muromumab. The first biologic approved by the FDA in 2003 was Elifacept for the treatment of the moderate to severe plaque psoriasis. Actually, biologics is invented for the other diseases, and we are very much fortunate that biologics is in our #1 weapon nowadays. So, very important thing is understanding the classification of biologics. Very, very important thing. Like #1 is monoclonal antibodies. #2 is fusion antibody proteins. #3 is recombinant human cytokines and growth factors. And #4 is intravenous immunoglobulins. In our journey in dermatological practice, and especially for the psoriasis, we are mainly discuss about the monoclonal antibody and the fusion antibody proteins. So what is monoclonal antibodies? These are produced by the single clone of cells. Single clone, very important. What the targeting specific surface receptors. One very important thing, all monoclonal antibodies names end with the stem mAb. So infliximab, rituximab, all mAb is monoclonal antibodies. M for monoclonal, AB for antibodies. That means anything in the end of any biologics written as mAb is monoclonal antibody. Very important. #2, another thing, there is chimeric. You can see there is a chimeric means, what is chimeric? Means the murine proteins. Murine proteins means the protein collecting from the rats. And fixed with and binds with the human proteins. So that is called the chimeric. So chimeric means XI, it denotes the XI. That means infliximab. Z means that is chimerics. 30% protein comes from chimeric origin, 30% from human origin. That's why it is called Z. Next one is the humanized. Humanized means 10% still protein or cell comes from the chimeric origin. That's why that is called ZOO. That means ifalizumab, means it's humanized. There is 10% chimeric origin, 90% is the humanized. And the total human sequence by humanized, that is called U. That means UMAP. That means one example is the adalimumab. And another interesting thing that is called the immune system. So early we call Li. Now it is called I. That is infliximab, Li. It's related to the immune system. It controls the immune systems. It regulates the immune systems. And specific target like the interleukin, specific. Then we use Ki before, now K, like ustekinumab. So these nomenclature is very, very important for the dermatologist to know the property, know the criteria of the biologics. Fusion antibody products, also called the chimeric proteins. Recombinant fusion proteins have also been produced by combining human proteins with bacterial toxins. Fusion proteins in the human antibodies are bound to the human receptors and with a sept. So any sept, like heterosept, denotes the fusion antibody proteins. So now we understand what is monoclonal antibody and now what is called fusion antibody proteins. So what are the principal fusion antibodies? We already mentioned that for the psoriasis that is called heterosept and the eliphasept. And heterosept is a fully human dimer fusion protein and eliphasept is recombinant fusion proteins. So one thing for the young starts and the new doctors, what is recombinant? From where we collect the human cells. Like we usually use from placenta or the ascitic fluids. And we can copy it, million copy. We can copy it. So this copying process is very expensive. So recombinant human cytokines and growth factors. Recombinant cytokines and cytokine antagonists produced by the recombinant DNA technology. Already I mentioned it. Used as immunomodulators for malignant and the inflammatory dermatosis. So which cytokines and growth factors are important for the psoriasis? That is interleukin 4, 10, and 11. Intravenous immunoglobulins is a fractionated blood product consistent of Ig antibodies. That means it is like a concentrated antibody, like we use the PRP, platelet rich plasma. That's why this is this type of product is a fractionated blood product rich in the IgG antibodies. IgG is currently FDA approved in dermatology for the graft-versus-host disease, Kawasaki syndrome, connective tissue disorders, autoimmune bullous disorder, toxic epidermal necrolysis, and the pyoderma gangrenosum. So one question, why biology is expensive? Because more expensive manufacturing products, because we have to copy it 1,000 and million copy. And this copying process is very, very delicate. That's why a manufacturing plant is very expensive. Higher cost in research and development, very, very high cost in research and development every day. Not that much competition, that is also a cause. And use of prefilled syringe. So you all know that prefilled syringe is expensive. That's why biologics is expensive. Initially, it is out of range in our hand. For Bangladesh, when we started 2-3 years back, then one dose Cosentyx is around 1,20,000 per dose. Xolair is around 56,000. Now it reduced a lot. Now everything is affordable now. I will discuss later on about what are the biologics is available here, what is the cross prices and all these things. Biologic drugs actually treating psoriasis, it's a big list. You have seen all these things. I don't want to mention all these things, but I want to surely mention what is available in Bangladesh. We'll discuss on that. The biologic scenario in Bangladesh. What are the biologics available for Bangladesh? Cosentyx, that is secukinumab, especially for the psoriasis. There are other biologics for the other, like rituximab for the blistering disorders, other Xolair for the urticaria and other so and so on. But for psoriasis, Cosentyx, secukinumab, adalimumab, adalimumab, etanercept. Cosentyx is actually brought from Novartis, adalimumab is healthcare, etanercept is from healthcare, and Remicade, infliximab from Unimed Unihealth. Simponi golimumab is also for the imported by the Unimed Union, but this is mainly used for the psoriatic arthritis. That's why they are not approached to us for use of the psoriasis. But we can use as alternative regime for the psoriasis as well. What are the fear factors? That is very, very important. Why we are reluctant to use biologics in our daily treatment? There is so many giant professors are here, so many practice, a lot of practice with the mid level, and so many doctors are there. But they have. I will show you today how we could introduce biologics into our daily practice, because there is a lot of big market here. So what are the fear factors? Resuming control, always fearing about, if it is not treated well, then I have to resuming back to the conventional treatment. Then what can I say to my patient? Fear of adverse effect like tuberculosis and infection written in the book. Fear of losing patients, that is another fear. Lack of confidence in prescribing, patients dropping out from the biologic treatment due to different factors. Contraindication with the live vaccines, compromise with the immunity, and dosing confusion, and safety in the pregnancy. These are the main things actually come in our mind to start before a biologic treatment. 40% dermatologists fear that while resuming back to the conventional treatment after biologic treatment, will it work? Yes, it works. It works like magic. Tips for the new users. Most doctors fear using newer treatment due to the unawareness. Side effects are rare for the targeted therapy. Very easy to inject. Patient satisfaction is very, very high. There is a difference between the real world evidence with the adverse event data, because every adverse event actually notified, and there is a presentation, there is a research paper. So we always actually pointed about the side effects and all these things. Doctors with less experience and usually reluctant and discouraged to adopt the newer treatment options. Why we choose biologics in psoriasis? When traditional treatments are not working. Psoriasis is mild but rarely bothering. Psoriasis is mild but rarely bothering. Very important thing, right? Because some patients want, I don't want to use daily creams. I don't want to take the pills. Patients would prefer to take fewer doses. Once in a week injections, once in a month injections, once in a 3 months injections, once in a year injections. They want this type of, and disease will be comes and go. We all know that. So disease remission process is 1 year, 2 year, 3 year. That is very much accepted by the patients. Current therapy is causing side effects. If we use a methotrexate or cyclosporins or acetretin, there are a lot of side effects and patients is really suffering. They want to have something beyond this. Patients want to improve their quality of life. Psoriasis patient journey in Bangladesh, very important. Most of the patients try to self-treat first. If there is any lesion appears in the skin, most of the patients wants to use some local treatment like local Vaseline or glycerin or like this. They want to treat by themselves. Some of choose homeopathy for the first few years. If symptoms intensifies and plaques appears in hand, feet, and they visit quack, GP, primary care practitioners. When the traditional therapy fails to manage symptoms and patient experiences flare-ups, they visit dermatologists. After first few visits, the symptoms worsen, and only then visit their previous consultant or choose another dermatologist. Some patients are maltreated by using the steroid by the quack or the GPs or anything. Some patients treated inadequate dose of methotrexate. Most of the centers have lack of facilities of adjunct therapy like phototherapy, lack of documentation like histopathological report before initiation of treatment. Prospect, very, very important slide. Please hear carefully. We all know that around 1 to 2% of the population of the whole world is suffering from psoriasis. There is no data of prevalence of psoriasis in Bangladesh, but we believe that 1% around, or 2% patient, 1% actually, patient is suffering from psoriasis in Bangladesh, around 1%. So our total population size is 18 crore, right? So 18 crore patients, around 1% is around 1.8 lakhs. And we all know that Bangladesh is booming and there our buying capabilities increased. So our capable patients for treating, for having psoriasis treatment is around 1%. That means 1.8 lakhs is capable. So according to psoriasis patients, 1.8 lakh, there is 1% of psoriasis patient, that is around 18,000 potential patients are around us, 18,000. So we have only 500-600 dermatologists in the Bangladesh. So we have plenty of patients, so no problem. If there is increased demand of biologics in future, price must be reduced. So now I want to discuss specifically the monoclonal antibody secukinumab, because it is very much available and shows efficacy in our patients. So I want to discuss with secukinumab first. So pharmacology is ৎসকব is a recombinant fully human monoclonal antibody. There is no chimeric protein that selectively binds to and neutralize the pro-inflammatory cytokine, that is IL-17. It is produced in Chinese hemisphere ovary cells. Chinese hemisphere means Chinese mice. Target IL-17. Humanized means we all know 10% chimeric and 90% human cell, right? It's called humanized. And bioavailability, so targets is IL-17 and inhibits the interaction with the IL-17 receptor. Bioavailability is 73%. Half-life is 27 days. So mechanism action, tumor necrosis factor alpha activated dendritic cell, that is called the antigen presenting cells, right? Presented to the T17 cells. Secukinumab selectively binds with the IL-17 and treats. We all know that IL-17 cornerstone cytokine involved in the development of the systemic inflammation in the psoriatic disease. Treatment plan and dose regime. Starting doses 300 milligram by subcutaneous injections in the week 0 and first week, after second week, after third week, and the fourth week. Then maintenance dose is 300 milligram every 4 weeks. So this is the data, and I will show you, because I will start with the 300 milligram subcutaneous injections later on because the expensive. Then I have gone through a literature. Then I found that 150 milligram is equally effective for the psoriatic patients. Then I started to giving 150 milligrams. So the dose burden and the expensiveness actually reduced a lot, reduced down to like anything. We can see 300 milligram versus the 100 milligram. The 50% reduction of PASI score at 3 weeks. And equally 150 milligram, that shows 50% reduction in PASI score in 3 weeks. PASI, there is a mistake in the slide. PASI 75 was maintained over 52 weeks in 80% patients with 300 milligram. And 150 milligram PASI 75 was maintained over 50 to 60%. That is 20% difference, but still there is impressive results. PASI 75 was seen over 2-year period, 88.2% patients. Interestingly, PASI 75 was seen over 2-year period is 75.5% patients. So if we use the 150 milligram, then there is a very, very less money involvement and patient will be happy like anything. So we can start actually 150 milligram. So what are the pre-treatment evaluation? We all know that it is written in the book, complete blood test, liver function, renal function test, SBSAG, NTHCV, NT-HIV, Montauk's test, chest X-ray, quantiferon TB gold, ANA, urine RME, fasting blood sugar, 2 hours of the fasting, ECG, ultrasonogram, whole abdomen, pregnancy test. Monitoring during therapy, CBC every 12 weeks. Very less monitoring guideline. Only chest X-ray annually. and quantiferon TB gold by Monto test annually. So very less monitoring during therapy. Adverse effect written in the book: injection site reactions, infection, diarrhea, headache, neutropenia, hypersensitivity and urticarial angioedema, ৎসকব antibodies, others pruritus, hypertension, arthralgia, back pain. But actually, in my experience, I found only few injection site reactions, nothing. I've tried everything and meticulously searching everything. Is there anything with the immune depressions or other antibodies or anything? We got nothing. Contraindication is hypersensitivity reaction and pregnancy category B. Next, the adalimumab. Actually, it is imported by the healthcare. Pharmacology, we all know that recombinant fully human monoclonal antibody against TNF-alpha, produced from the Chinese hemisphere over again, the function by specifically binding TNF-alpha and obstruct the interaction with the P55 and P75 cell surface TNF receptors. Bioavailability is 64%, half-life is 2 weeks. Mechanism actions, intercellular signaling mediated by the TNF occurs through the interaction with the cell-bound TNF receptors. Treatment plan and dose regime. Day 1 is 2 subcutaneous prefilled syringe. Day 8 is 1 subcutaneous prefilled syringe. So there is a one loading dose is 2 subcutaneous is 40 milligram prefilled syringe. And maintenance is 1 subcutaneous is every other week, in every 15 days. So price of the adalimumab is 40 milligrams is 15,000 only. And price of the, I missed that slide, mentioned that secukinumab is around 26,000 around. Clinical response, week 16, 71% achieved PASI 75, 45% PASI 90 and 20% 100, PASI 100. And week 33 to 52, patients who achieve PASI 75 at week 33, lot of PASI response by week 52 on stopping adalimumab. So pre-treatment evaluation, I already mentioned it. Monitoring drug therapy, CBC 12 weeks, LFT annually and CXR annually. Adverse effect, again, specific for injection site reactions, infections, demyelinating disorders like CNN, CNS, multiple sclerosis, Guillain-Barré syndrome, pancytopenia, bicytopenia, thrombocytopenia, hypersensitivity, arterial angioedema, anti-drug antibodies. Contraindication is hypersensitivity reaction, live vaccines, pregnancy category B. Etanercept. So fully human soluble recombinant TNF-alpha receptor antagonist. It's a dimeric fusion proteins, binds with, neutralizes both TNF-alpha and TNF-beta. Bioavailability is 58%. Mechanism action. Already I mentioned, inhibits the binding TNF-alpha and TNF-beta to the cell surface TNF receptors, then rendering the TNF biologically inactive. TNF inhibition downregulates the multiple inflammatory pathway. It results the apoptosis of dendritic cells in psoriatic plaques. So clinical response again, 50 milligram twice in a week, 64.2%, and PASI 75 is 49%. 25 milligram twice in a week, 52.6% and 34%. 25 milligram once in a week, 40.9% and 14%. I have clinical experience with secukinumab and the adalimumab. I have no clinical experience with the this etanercept. So this data is provided from the books and from the journals. Treatment plans. For psoriasis, starting dose is etanercept 50 milligram twice weekly for 3 months. Maintenance dose is etanercept 50 milligram once weekly. Pediatric patient dose 63 kg or more, 50 milligram once weekly. Less than 63 kg, 0.8 milligram kg once weekly. Price is 25 milligram is 8,000 taka only, and the 50 milligram is 13,000 taka only. Pre-treatment evaluation is same. Monitoring guidelines is almost same, except Montux test annually. Adverse effect here is injection site reactions, infections, malignancies. Yes, one question actually, is there, if biologics initiate any malignancy? Yes, for the etonercept. That is called basal cell carcinoma and the squamous cell carcinoma. Anti-drug antibodies, exacerbate pre-existing heart failure, demyelinating nerve disease, and hepatotoxicities. Contraindications, hypersensitivity reaction, patients with serious infection, all these things. So there is a injection techniques. Actually, I want to show you that is very, very easy. You see, I just start the video and you can see it. That is a very simple thing. If there is 2 injection site, we will use both sides of the abdomen or the both sides of the thigh. It's very easy. There is a pre-filled syringe, and I will show you it's to inject very safely and very adequately in the subcutaneously. See, sorry. You see, just open the needle. You see, there is a pre-filled syringe, and like this, direct push. And you see there is a spring in the bottom. It will help to prevent any injury to the injection sites. You see, finished. Thank you.
Thank you. Thank you, Shamim Bhai. It's great, indeed an excellent presentation and a very informative. Indeed, to many of us, biology is still a hard nut to crack. And you made the things quite presented in an easier way and encourage us to try it at least. So, and with your proficiency, you have made this critical issue very palatable to us and for us and the junior dermatologists also. Now, the question answer sessions, I would again ask all our valuable participants to please drop your questions in the chat box. And during this time, I would like to take the opportunity to ask questions to some of our expert panelists. Samuel, sir. Yes, sir. So you're the founder, president of the Psoriasis Awareness Club. What is your experience so far with the biologics in your personal practice? How many have you applied or tried?
Okay, it's a nice question. As a president of Psoriasis Awareness Club, the motto of our Psoriasis Awareness Club is to aware the patient regarding psoriasis and to bring up their quality of life. Thinking in this in our mind, we have to think what are the new options we have to give to the patient. Anyway, for my personal experience, I can say I have given some of the patient with biologics, especially the secukinumab and adalimumab. So this
the outcome was,
I don't want to give what I want to say that it is not that the patient is coming to me, any patient coming to me, I will ask them to take. No, we have to screen the patient first because there are systemic drugs around 10 to 15% used to take this systemic drug. Among this systemic drug who fail to respond with the conventional treatment and whose quality of life is getting worse day by day and they have no other option, for them, we can think for the biology. It is not that the patient with severe will put him on biologics. No, we have to think how to give them whether giving the medicine is applicable or not. With this few patients, we can start this biologics. I can give you an example. One patient who has generalized psoriasis and he was working in a high official and he was suffering from this psoriasis on and off. Once he was given a job in Saudi Arabia. His visa was rejected. Why? Because of his severe psoriasis. How devastating is the condition? And the patient was refused to go to Saudi Arabia for his job. This is the patient I have started with the biologics, and the patient improved within a month. After the fifth dose, he was nearly, his PASI score is more than 75. So it was very good result I got, and the patient still continuing the drug, and he is happy and he is doing his job and he's very fine. This is the thing I want to mention. Like another patient I have given, there are other patient also. This one I want to mention is that because why I'm giving, he has only psoriasis on his hand. It's only less than 1%, but in other body part, he has very minimum. He is also in high officials. He can't do handshake with his friends. He can't do his official works. He always put his hand on his pocket. He can't go to any meeting or he can't do any social gatherings. So that patient need this biologics, and he was improved with this one. Definitely, I tried few patients with adalimumab, but the response with secukinumab is excellent. And adalimumab, it is good, but not as secukinumab. At least this PASI 75 you can reach after 6 months or 8 months like that. But with my experience, I think the secukinumab could be the best treatment with less side effect and best option to use.
Thank you, sir. Thank you for sharing us with such an inspiring experience. So why is the risk of malignancy while using biologics? Is which factor that increases the susceptibility of malignancy?
Yes.
Samil, sir.
Yes, the malignancy actually, biologics, few of the biologics, TNF inhibitor, what we are using, that is adalimumab, influenza and etanercept. These are the drugs, these are TNF inhibitors. If you use with methotrexate, or if these drugs are used with other options, if the patient is exposed to phototherapy before, then there is a chance of getting psoriasis, malignancies more. For usually the psoriasis patient, there is a chance of malignancy. Without using any medication, there is a chance that there is a chance of malignancy. But if you use this TNF inhibitor, there is a chance a bit more if you use it with the other options also. But with the newer drugs like secukinumab and other, there is also less chance of getting this malignancy using the drugs. But other than using the drugs, there is a chance of malignancy with the psoriasis patient.
Thank you, sir. Now I would like to ask a question to Professor Kobi Chaudhary, sir.
Dr. Yasmin.
Yeah. Yes, Shamin.
Can I add something here?
Hi. Hello. Yes, I can hear you. Yes, Shamin bhai.
Can I add something here regarding malignancy?
Yes. Of course, you go on.
In the study, actually, they are warn us that should be avoided. There is no clean-cut evidence to inducing malignancy by any biologics, but there is a warning, because if you treated or you cured from malignancy, you have a history 10 years back, then there is a chance of induction of malignancy with the use of some biologics. Thank you.
Thank you. So related to this, Dr. Shamim, please can you unmute him? Related to the malignancy, as you mentioned, like if a patient who has been treated for stomach carcinoma, now onto a biologic with psoriasis, for psoriasis, is there any, again, increased risk for him for the recurrence or developing a different type of carcinoma, like SCC or BCC?
Because one thing, the stomach carcinoma is very much fatal, and there is there is no chance to use biologics because there is no
like something, any anybody like who has recovered from any sort of malignancy, like a blood.
Stomach cancer is very much fatal. There is a very less chance of cure for the 10 years. Survival rate is very less.
Okay, then let's.
Yes, yeah, we can safely use. There is a warning only, the red level warning only for not to use in treated or malignancy. There is no data yet to ensure that there is the induction of malignancy through the biologic treatment. That is my point.
Okay. Okay, got your point. So that is, it is safer in terms of not induction. Okay, thank you. Now I would like to ask Professor Kobi Chaudhary, sir, why biologics increases the risk of tuberculosis? Though it is in the screening guideline, but what is the practical scenario? The patient really gets susceptible to tuberculosis during the treatment.
Bismillahirrahmanirrahim. Thank you very much for this nice question. And everywhere the people are thinking that before you start, you need screening, including tuberculosis screening. But in modern the biologics like secukinumab or ixekizumab, secukinumab or brodalumab, and these newer biologics, they go the pathway of the inflammatory cytokines, and usually these 3 or 4 newer, there are 11 biologics so far FDA approved, and only the anti-TNF drug may causes tuberculosis, but not the newer biologics. So now tuberculosis, there is a research in England and United States, in North America, in whole world, 29% of the tuberculosis in this Southeast Asia region, and out of this, and Bangladesh only 4% chance of tuberculosis in our country. And this 4%, we can do the before and after, even during treatment, and every year we need, already Dr. Shamim mentioned, we read in between treatment, we need some screening before the treatment and after the treatment, because it reduces the immunity. Because of the immunosuppression, there is chance of the patient has no tuberculosis, but there is chance of tuberculosis. He was a carrier, or he had not given any vaccination. They may induce the tuberculosis, but the chance is very, very low, and only in the TNF alpha, not in the secukinumab, ustekinumab, or gestokinumab. And the chance is not that much. But tuberculosis, yes, we should keep in mind, we should have a screening of the tuberculosis, like the gold standard test, or by this IgRA, a very new test approved by the FDA. We could go with the IgRA test, and all by the STS test. And the cause is because of the immunosuppression. But as far we think so much, but it is not that. It is only a fear. Not in practical life, it is not induces so much tuberculosis in our country and any country. Western world, no chance. Now in America, they stopped doing screening in between the test, because it is a costly, and mostly it is negative. There is no chance of tuberculosis. But for endemic country, or a patient who is living in the United States or in European country, if they travel too much to the eastern region, they go for this screening, but not the other patients. It is only assumption, not that much practically risk in our country also.
Okay. Thank you, sir. Thank you for the very informative question.
Can I have a
yes,
comment?
Sir?
I'm Professor Rashid. Can I have a comment on
yes,
this?
Sir.
Thank you, Shamim, for your nice presentation. My talk about on TNF alpha is actually TNF alpha is a cytokine. It walls of the tuberculosis. Heal tuberculosis, neither is latent, it walls off. When you give a TNF alpha, this wall is broken. There is a chance of the activation of tuberculosis. So I think we should go for, in case of using our TNF alpha blocker, we should be more careful. But TNF alpha is a cytokine which walls off the tuberculosis focus in a patient of tuberculosis. Thank you.
Yeah, that's why there's only TNF alpha we can avoid, and we can do careful about tuberculosis, but not the newer drug, secukinumab, ustekinumab, or gestokinumab. Yes, you're right.
Yes, thank you, sir. Thank you for this inspiring information. Now, can I ask Brigadier General Dr. Abdul Latif Khan, sir? Sir, can we take 2 biologics at a time?
Thank you very much. The answer is simply no, because the biologics works in our body, it will suppress our immune system. Though it is selectively suppress our immune system, and our immune system is responsible to prevent the development of disease or infection. So if we add 2 biologics at a time, they will be more vulnerable to infection and diseases. And I like to highlight a few points regarding the psoriasis. We know that the interleukin 23 and 17 pathway plays a central role in pathogenesis of psoriasis. So nowadays, the interleukin 17 drugs like secukinumab, isexizumab, brodalumab, and bimekizumab, and interleukin 23 inhibitors like gaselkumab, risankizumab. These are the drugs are now coming promising for the treatment of psoriasis, other than the TNF alpha and 1223 inhibitors. Thank you.
Okay. Thank
and
you,
I
sir.
like
Again,
to add another point, that one of our patients responded well, psoriatic arthritis responded well with the infliximab, but unfortunately, later on he died due to tuberculosis. It is probably due to lack of screening or follow-up, probably. This is one example I'd like to share.
Thank you, sir. Now moving to Dr. Shanghai. This is a question from the chat box, directly asking to you, someone. What are the frequency rate of relapse that you have seen after giving secukinumab? And in your case?
Relapse case, are you getting me?
Yeah.
Relapse case is not the important. We actually follow the PASIS course. We already mentioned clearly that it clears up to 100%. And there is actually drug holiday. You understand? The drug holiday for 3 months. So if we maintain, you see that there is a maintenance dose. If we maintain the dose properly, a chance of recurrence is very, very less. I've not seen yet.
Okay, thank you. Then moving to...
Just add one of this question. So nicely answered by Dr. Shamim. But relapse in case of biologics, up to 5 years, no chance of relapse. But in my patient, one of my patients, I've given him this secukinumab. Interestingly, he was completely cured after four injections. But suddenly he came with relapse. How? He went to India. He gave the question asked to Brigadier General, and he answered it. The 2 biologics together is not actually should not be given. He went to India. They gave etanercept. So after giving another biologic, he came to me with severe relapse, but not relapse due to biologic. He changed the switch of the biologic. He crossed even the 3 months. That is the holiday of the treatment. After 3 months, he went in India and he gave another biologic. So you should be very careful not mixing biologic together or giving 2 biologic together. Thank you.
Thank you, sir. Now moving to Professor Samin sir again. So
can I have a comment here?
Yes, sir. Rashid sir.
Okay. The thing is, I want to make something clear. We are talking about psoriasis is a hyperactive immune system. The biologics has the function of normalizing it. Actually, the term, if you're going to get immunosuppressed, is not right. I think there are certain situations that certain fungal infections may flare up, but that's what we do with the biologic, because it's targeted. It's a very good treatment. It tries to normalize the hyperactive immune system. And the thing is about the cytokines we are talking about, like interleukin 17, IL-12, 23, even TNF alpha. All the biologics are good. And we are talking about the IL-17 blockers, they are very good. Even the latest ones like guselkumab, filtokizumab, risankizumab, what the focus on only 23 only. They are even said to be even better. These are upstream cytokines. You have to take less injections, but after another. Even if these biologics are not, there are times it happens that 17 is not working, IL-23 blocker is not working. A TNF alpha may work better. So there are studies like that. So all of them are good, but we always try the downstream cytokines like IL-23 blocker and the latest one like IL-23 blocker. But don't just think that even the TNF blockers may be very good in certain situations. Thank you.
Thank you, Rashid. So can I add something?
Yeah.
Can I add something? Thank you, Rashid sir, for
sure.
Yes. That is, main thing is it reduces the flax tremendously. So quality of life is increased like anything. Reduce the flax, reduce the itching, reduce the inflammatory burden. So all the advantages of biologics. And one thing I forget to mention in my presentation, that is the comorbidities. All the comorbidities actually good and improved in biologic therapy, like it's cardio. Nowadays, it's called biologics are cardioprotective. You understand? Metabolic syndromes are less stress, less all these things. So it is cardioprotective and positive effect. So with the comorbidities, biologics is a good choice. Thank you.
Thank you, Shamim bhai, again. Then Professor Samuel sir, recently we have been listening to the term drug holiday and drug antibody. Can you, sir, please explain these two terms? What is a drug holiday for biologics, and what is the drug antibody? Professor Dr. Samuel Haq. Please unmute, sir.
Unmute.
Yes, sir.
So drug holiday is that when you are giving, especially we are talking about the biologics, when you are using the biologics and suddenly you get a break. Why you get a break? This is a question. Maybe after 1 month, patient is cleared up, so he will stop his drugs by his own. Or he develops some reaction, that's why the drug was stopped. Or he had some monetary problem, he cannot buy the drugs. Different types of problem, usually the patient used to stop using the medication. So this holiday is that the holiday for that biologics or that drug. If we want to reuse it again, there is a question whether when he will use the medication again, the response will be the same as before or not, it is a question. Usually we have seen that the TNF inhibitor, when you are using, especially the adalimumab and infliximab, when we are using, if you go for drug holiday and if you reinstitute the drug again, the efficacy is very low. It is not working like before. This is one. And other drugs, some of the drugs are doing like this, and some of the drugs like etanercept, when you are using, if you go for drug holiday, and after drug holiday, if you reinstitute that drug, it will have a very good effect. So the drug holiday is good, drug holiday is bad. Usually for biologics, we are telling that we should not stop using biologics unless it is indicated. Or if the patient stop it, it is for his own. But we should not ask the patient to stop the biologics. It has to go on maintenance therapy. And what about the antibody? Antibody, usually it is an immune drug, you know. It can develop an antibody at any time. Any drugs, usually these TNF inhibitors, they are usually developing this antibody. Sometimes when you are using these drugs, it causes some reaction, some antibody reaction it has. That causes antibody, or by its own, it can develop some antibody. When it develops the antibody, the drug's efficacy and effectiveness is definitely reduced. It will not work. So in that case, we have to think to change the drug in other form of biologics.
Thank you, sir. Okay. Now, from the chat box, the question to Dr. Abdul Latif, sir. Can biologics be used as a monotherapy?
Biologics, yes, biologics can be used as a monotherapy, but it can be used in combination therapy also.
Okay, thank you, sir. Again, Mr. Latif, sir, Can a patient ever stop biologics, like either with a clearance of attaining PASI score at a desired level? Can we stop? And what are the indications of restarting?
Thank you. To stop biologics, there are certain situations you have to stop. That is, failure to maintain a significant improvement. If drug is not satisfactory improvement, in that case, you have to stop the biologics. Second one is if there is serious adverse events. In that case, you have to stop these biologics. Another is before elective major surgery. In that case, you have to stop, and certain vaccination, that is live vaccination, before that, you have to stop it. And also in case of before pregnancy, you have to start it. But before restarting, there are some problems like infliximab. Only a single course you have to start, because if you stop infliximab and adalimumab, they will develop anti-drug antibody and their effective is less. But in case of etanercept, you can start intermittently, and even good effect also observed after 6 months also. And ustekinumab, you can also use intermittently. So these are the drugs you can safely use. And recently there are a lot of drugs available. We'll later discuss later on.
Thank you, sir. Now, another first question to Dr. Rashid Mohammad Khan, sir. During this, sir, can you hear me? During this COVID pandemic, sir, is it safe to choose biologics for a patient? And what about the vaccination? If the patient arrives his scheduled vaccination for the COVID, will he take the vaccine or withhold the biologic dose?
A very, very interesting question, actually. But I have tried to go through the studies that has happened, and very recent studies have shown that those patients who are on biologic are safer than those who are on systemic drugs like methotrexate. The biologic patients are safer. And it is recommended that you don't have to stop any treatment, because you have to, each patient should be individualized. You have to individualize each patient, you have to assess the risk and benefit. If the patient is risky, you can stop the systemic drug or even biologic if there is a severe contraindication. Otherwise, no drug should be stopped. There are concerns about cyclosporine, since it blocks the T cells. So there's concerns about methotrexate. And we have seen that active labs, even tofacitinib, are said to be safer in using in a COVID situation, but all the biologics are found to be safer. Even in certain situations like TNF blockers, IL-17 blockers are said to be better in a patient who is suffering from COVID. Because in COVID, the cytokine storm involves TNF alpha and IL-17. So if those cytokines are blocked by a biologic, sometimes the cytokine storm also is not that severe. So if there are certain situations, the biologics are even better in case of COVID situations. So the thing is about vaccination. Never miss a chance to take your vaccine. That's the rule. And for biologic, what you can do, that you can don't start a patient on biologic. When you think that you're going to start a patient on biologic, don't start it. And you can delay the second dose after of the biologic when the patient is vaccinated. But all the patients have to take the vaccine in due time and right time. That is the recommendation.
Thank you, sir. Such a good and golden advice.
At one point.
Yes, sir. Yes, sir.
Thank you. In January 2021, there was a large study was done. Here they have shown plaque psoriasis treated with biologics more than 6 months were not at greater risk of COVID-19 related death or hospitalization than individuals in general population. So it is very much safe in this COVID-19 situation.
Thank you, sir. Now, moving to COVID, Chaudhary sir again. Sir, people with psoriasis now who are showing inadequate response, inadequate PASI score, what strategy should be thought Should we switch over to other, or what would you do, sir? What would you recommend?
Number one, to find out the cause of inadequate response. Number one, the choice of the patient. Which patient to given biologics? There is moderate to severe plaque psoriasis. Number one. Number two, the patient has got sepsis. We give some biologic, and that may fail. We should be very much positive about choosing the patient to whom give. The patient is suffering from some herpes zoster or herpes simplex, any viral disease. We should be very careful. Or a patient is got active tuberculosis, we should be very careful about taking the choice of the patient. A patient is pustular psoriasis or erytherodermal psoriasis, you should not choose. We should find out the cause why the inadequate response. Most problematic is the anti-drug antibody. Anti-drug antibody is the most problematic thing. When anti-drug antibody pump on one biologic, we can switch over to another biologic, giving the wash out of the previous drug. Wash out time of a drug, maybe 1 month or 2 months, completely stop the previous biologic, then we can go for this another drug. Or the patient has got some sepsis, some viral infection, some bacterial infection, or tuberculosis. We give the treatment or the prophylaxis for the tuberculosis. Then we switch over to another biologic other than the if it is tuberculosis, other than the TNF alpha. So this is the strategy of a patient if he is not responding well, or not the patient receiving the treatment, not getting the good result, or PASI square, or the BSA is not is coming down. So you should be very careful. Whoever the patient, it is individualized. So Dr. Rashid was telling, individualized. Individual patient should be given completely check up about why it is not working. We should not jump. They is not working. Go to another biologic. Find out the cause of not adequate response. If cause should be treated, then we can switch over any biologic or non-biologic or other drug. So it's very, very important. And when a patient is failed to have conventional treatment like methotrexate or cyclosporine, then we take the biologics. We should not go first drug to not be biologic. The Western in the world, all the South American, North Americans say the number one is biologic, number two, the choice is biologic, but I don't support it. We should give in the conventional treatment. If it fails, then we go for the biologics.
Yes, sir. Related to that, if a patient has recently completed his or her chemotherapy, like for suffering from any lymphoma or something, will he or she will be a good candidate to receive biologics?
Very interesting. When a patient is taking, all the chemotherapy patient taking steroid. So if steroid is there, we should withdraw the steroid, but even we can give chemotherapy and the biologics together, no problem. Because apoptosis of the cell is destroyed by the biologics, and also we know the killing of the cell done by the cytotoxic drug of the chemotherapy, and same thing done by the biologics. And biologics has a specific cell apoptosis they control. So we can give, a patient is completed his chemotherapy, yes, we can start biologics for the patient if indicated. Very important, choice of the patient, if indication individualized. We should individualize the patient. If patient is other drug not responding, and biology is the better choice if patient is complete his chemotherapy for psoriasis. And that is the main strategy, is very good, the biologic, then the other drug to given to that patient. Yes.
Thank you, sir. Thank you for giving us guidance in such a critical situation. Yes, sir.
Can I have a comment right, about the lymphoma and also bullous disease? Even SLE, we are using rituximab, which is a B-cell blocker. And in this situation, B-cell is very much important for the production of antibodies. So those patients of lymphoma have using rituximab. Even I have patients of biologic rituximab on bullous disease. So you have to stop that biologic. Those patients, you cannot give any other drugs that are going to influence the immune system. So that is a special situation. In those cases, we have to be very careful about selecting biologics.
Thank you, sir. Now move.
There are some study, the psoriasis patient develop lymphoma after taking these biologics. But then ultimately there are some research also, they showed that some patients also cured their lymphoma. It is already, Dr. Had was saying one thing, that this individualized. If there is one study and there's lymphoma, the biology causes lymphoma, but there's so many studies, biology can cure lymphoma. And so we should be very careful about choosing the individual patient and who after taking the chemotherapy. Thank you.
Yes, thank you, sir. So we understand the treatment has to be tailored according to the patient. Now moving to Dr. Shamim, someone in the chat box has asked which biologic would be safer during pregnancy if it has to be used? Which biologic is safer during pregnancy, or should it be withheld?
Indicated almost. No biologic is safer in pregnancy.
It's category B, you said, yeah.
Yes.
Okay, I hope you got the answer.
Can I add? There are so many studies on the pregnant woman and also the breastfeeding. So many studies done. And there are so many patients who had completed the pregnancy and childbirth without any problem with the fetus. But there are some organ defect. There is some organ defects. Category B, there is no teratogenicity, but organ defect, atresia or some valvular disease or something. Some organ defect is there found, and so many, because the patient is pregnant already in between they will stop the drug. But in early, the patient should be given cautious. They don't be pregnant. But if they're pregnant, there is no indication to terminate the pregnancy, continue the pregnancy, and there is few research paper. There are some organ defect, not the total teratogenicity. So we should be very careful, caution. Not already. Dr. Shamim was saying caution. You should be very cautious taking the pregnancy. Once it is pregnant, yes, we should be careful. And in breastfeeding, the very minimum amount secreted with breast milk. And also when a person gave birth to a child, they should continue their breastfeeding, not stopping it. Yes, thank you.
Thank you.
Yes, now again.
I like to share one point, single.
Yes, sir. Yes, sir, Latif, sir. Yes, sir.
Or theoretically, all biologics are pregnancy category B. But it does not mean then all are safe. Only safety profile was assessed, long-term safety profile, TNF alpha inhibitors, especially certolizumab, pegol, and etanercept. These two are relatively safer. If you want to use assessing the risk benefit, you can use certolizumab, pegol, or etanercept. They have the long-term safety profile. It was studied. Thank you.
Okay, thank you, sir. So again, Sir Latif, sir, back to you. So do you think in the current scenario, will the biologics will increase the risk of fungal infection like the black fungus or something?
Thank you.
Is there any case report already like this?
Oh, thank you. This is a burning issue nowadays because this black fungus has become an epidemic in India. After post-COVID, recovered from post-COVID patients. And more than 10,000 people already affected. And its mortality rate is 50 to 60%. And basically it is caused by the mucormycetes molds. That is, spores remain in the soil, decaying matter, air and dust. And through nasal passages or respiratory passages, it enters into the body, and through sinuses, it affects the eye, even brain, and through skin, it can affect it in our body. And recently, they have shown that the COVID patient with uncontrolled diabetes and use of prolonged steroid and use of contaminated oxygen cylinder, they have become the epidemics in India. But it is basically a rare disease. And those patients are immunocompromised. That is, cancer with chemotherapy, organ transplant patient, they can also develop this mucormycosis. So, but for the biologics, no such case report was, we do not seen the biologics can cause the black fungus. But there are possibilities. Tocilizumab, they are in the, it is on the suspicion, but not yet established. And other fungus like aspergillosis, histoplasmosis, and candidiasis. These are the fungus, invasive fungus can develop due to TNF alpha inhibitors. So we must follow up during the treatment with TNF alpha inhibitors. And in 2008, 16 cases of histoplasmosis were detected after taking adalimumab. And in 2009, US FDA have given a black box warning. So we must cautious about this fungus. I don't know what about black fungus in later on. So far, it is not reported.
Okay, thank you, sir. Now back to Rashid, sir, please. During treatment, what are the parameters we should look for to assess the response or prognosis? And what are the safety profiles during each visit? I mean, what are the parameters we should look for as a prognostic factors?
Actually, these are the things we assessing the response. We go for PASI, for DLQI, PGS score, and actually there are very, very biomarkers that we can assess. We talk like we can, there are biomarkers coming up like IL-17, we can measure IL-17, or other cytokines we can measure, but now we have very few biomarkers except what we call is, what is that? Besides ESR said that there is another CRP. Yeah, we can go for CRP level. CRP is one of the biomarkers we can assess to see that whether the patient is going for remission. And another thing I want to add here that I missed that time about vaccination. The pathway, when we vaccinate a person, the pathway and the cytokines that are involved in producing antibody, B cell stimulation, T cell stimulation are not TNF-alpha, are not IL-17, are not interleukin-23. So again, for vaccine, the vaccine pathways doesn't involve the cytokines that are involved in psoriasis. So vaccination is again safe in a patient with suffering from psoriasis. Thank you.
Thank you, sir, making it again clear that COVID vaccine and biologics can go hand on hand. Now, to the COVID Chaudhary, sir, it's precisely to you. Sir, how to manage some special situations which may arise during the biologic therapy, like raised HGPT or reactivation of hepatitis or fulminant hepatic failure?
Actually, very, very interesting here. There is cardiac failure and hepatic failure. They goes together, because if the person have the cardiac failure, they may develop hepatic failure, edema and other things. And in case of biologics, if there is hepatitis B positive and B virus is the load is more than 1,000, we should be very careful about giving biologics. But you can give with the lamivudine treatment, that is the antiviral drug. With the antiviral drug, we can go with this. If you want to treat a case of hepatic failure and the virus load is more than 1,000, we should give lamivudine in conjunction with the biologics. And already Dr. Shamim mentioned that these biologics are the cardioprotective. Also, cardiac failure, the biologic will help for the cardiac failure. The patient will have, because there is chance of coagulation. And in biologic, they recanalize the coagulation, the places are coagulated, or there is some heart problem. And these biologics are very, very good drug. We are giving some antiplatelet drug, but biologic itself works as an antiplatelet drug, and the coagulation is prevented. So we can give this drug and maintaining the dose of the cardiac treatment, other treatment, hepatic treatment, and there is no contraindication in case of hepatic failure or cardiac failure to give biologics. Biologics can continue if we indicate it for the treatment of psoriasis and the patient is same time hepatic failure or cardiac failure, we should continue the treatment because it is not contraindicated in both the cases. So we can continue the drug, and we should be take care, and these cases we should be take help of the hepatologist and the cardiology to treat the cases. These sorts of cases we should be joint treatment into the cardiologist and the hepatologist. Thank you.
Thank you, sir. Thank you for breaking the myth which we are already afraid about while using biologics. So again to you, sir, how can we induce biologics to a patient like sarcoidosis or SLE who are already on bolus dose of steroid? How can we induce biologics to such patients? Should we stop the steroid dose if you had to start biologics in a patient with sarcoidosis or SLE?
Yes, because steroid and biologic can go together. It's very big because steroid, so much immunity is fall by the steroid. So if you want to give biologic to this patient, we should give it time to wash out the steroid from the patient, and effect of the steroid we should give the blood parameter, and if we can go the cortisol level, and cortisol level we should see that the effect of steroid is completely eliminated and completely wash out the steroid, then we can go start biologic in case of sarcoidosis or other diseases already treated with the steroid. We should stop the drug first. Thank you.
Thank you. Thank you, sir. Now to Dr. Shamim. There's a question.
I have a comment here. I have a comment here. Okay.
Yes.
About the recommendation of using steroid in a patient in COVID situation. It has been said, it's a very recent study, that more than 10 milligram of prednisolone is dangerous. If any patient is on steroid, more than 10 milligram, you have to try to taper that steroid below 10. So if it's above 10, it is dangerous. That's the latest recommendation. Thank you.
Thank you, sir, for such your good guiding information from your long-term experience. Now, Dr. Shamim, why ANA screening? We can guess why it should be hepatitis and tuberculosis screening. Why ANA screening before starting biologic in your checklist?
Thank you. Because ANA testing, some studies is there before that using some biologics can appear the vasculitis and the lupus. That's why. And now the studies shows that there is no need to keep this ANA test in the monitoring list, because there is no evidence nowadays. Since before some biologics shown that there is an induction of vasculitis and the lupus. Thank you.
Thank you for your in-depth answer.
We don't do it anymore. We don't do it anymore, guys, from now.
Huh?
Oh, so ANA is not done, Rashid sir, yeah? Not recently, it's not included in the list.
No, we don't do it now. Yeah. No.
Okay, sir. Okay, thank you, sir.
We should be very much thankful to Dr. Rashid. Tocilizumab using in India, they're using for the as a biologic for the treatment of COVID-19. So we should not be scared giving the vaccination in the patient taking biologics. So tocilizumab is extensively used in India. In our country, not that, but India. Yes.
Actually, tocilizumab is an inflammatory cytokine. It's an IL-6 blocker. IL-6 is a major cytokine in causing the cytokine storm. So that's why tocilizumab is very good. And there's a recent studies. And when there's a cytokine storm, it's not always good. If you give it before, that is good. When in a cytokine storm situation, tocilizumab is very good. And it blocks the IL-6.
Yes, it is indicated only when there is IL-6 is with cytokine storm. There are some situation when they think cytokine storm is there, they do the IL-6. If IL-6 is high or positive, then they give this tocilizumab. Yes, it should be used injudiciously. Because I attended some webinar in India and they're using so much, but the indication must be there. Yes, IL-6. Thank you.
Yes, from the chat box towards Dr. Abdul Latif sir. Can we start guselkumab in lieu of secukinumab as it has superior efficacy and safety in relatively infrequent dosing schedule? The superiority of guselkumab and secukinumab.
Thank you. The recent drugs, those who are acting on interleukins 17 and 23, these drugs are more efficacious and safety profile is much more better. So secukinumab is also better, guselkumab is also better. We can use this one. But another drug, interleukin 17, recent advancement I like to share regarding guselkumab and bimekizumab. Bimekizumab, there is a study, PASI 90 at weeks 52. There was 81.6% in comparison with ustekinumab, that is 55.8%. There is a gulf of difference. And at 4 weeks, PASI 75, 76.9% in case of bimekizumab and 15.3% in case of ustekinumab. And another is guselkumab. There is excellent safety profile for 3 years. It was studied. No risk of tuberculosis. And PASI 75 at week 16, it was 90% of the patient. And PASI 90 at week 16, 73% of patients. It was observed in case of Gasilkumab. So both drugs are very good. And safety profile also better, sir.
Brigadier Latif, I can just add one thing, and it is my practical experience. One of my patients was taking secukinumab here, but he went to the United States, and they changed it to guselkumab. And the patient is very happy with guselkumab, and she's saying that it is better and less side effect, less problem, and she's now completely cured. And she brings the injection from the United States and push the injection. For pushing the injection, she goes to Bangkok. Very interesting, very rich patient. And this is newer safety is very, very bright. Yes.
Recent and the bimekizumab is better option also. Recent, though it is not in the US FDA approved, but they are on the pipeline. So
FDA only 11
bimekizumab, these are the drugs coming up. These are drugs are coming, but it is not available in our country. But one webinar with Singapore, he has shared his experience that the drugs are excellent, sir.
Thank you.
In Singapore, sir.
Okay, thank you. I think
since we are discussing in context of Bangladesh, these are all theoretical discussions.
Yes, all theoretical.
We have to wait, sir.
But first theory, then practical.
Correct,
the mind doesn't know, I cannot see. We should discuss it.
Yes,
in future, we have to go the better options, sir.
No, inshallah. But Dr. Shamim very nicely presented the paper, and also he told we shouldn't be fear, we shouldn't be scared. We should start the treatment, and we should start the treatment.
The newer drugs are also very good safety profile.
Yes, and we should ask the company to already the secukinumab they reduce the price. Yes, so we should be very they reduce the price. Definitely.
Okay, thank you, both the doctors. I think Lieutenant Colonel Dr. Islam, I hope you got your answer in the chat box. Thank you. Now, moving towards again to Latif, sir, I think I must be asking you again, sir. What are the advices and supports that should be or that you should offer to your patient while prescribing biologics and their families and their caregivers? Which are the advices and supports to the patient himself and his families and or the caregivers?
Yes, very very big list of.
There are three groups.
I'll give you just a summary. We are using biologics that selectively inhibits TNF alpha, interleukin 17, 23, and selectively suppress our immune system. So, before prescribing biologics, we have to screening some that has already been discussed, active and latent tuberculosis screening, that is Montox test, quantiferon gold test, gene expert, then hepatitis B screening, HIV screening, and non-live vaccination we have to give, that is influenza and pneumococcal vaccination. But we have to avoid live vaccination. And during treatment, we have to advise the patient for follow-up like invasive fungal infection for TNF alpha inhibitors, already discussed, malignancy, lymphoma for TNF, and interleukin 23 inhibitors, squamous cell carcinoma and basal cell carcinoma, and suicidal ideation for brodalumab. These are and already we have discussed that in case of pregnancy, we have to stop it. And if there is risk benefit is assessed, and then we can use like certolizumab or pegol or etanercept. And efficacy must be shown gradually. It is diminished in case of biologics. So we have to assess it, and then we have to switch over also another group or another biologics, as it has also been discussed. So we must observe that anti-drug antibody can be developed, and it has reduce the efficacy of the drug. So it has to be monitored. And risk benefit also should be assessed during the COVID situation, though there is less chance of adverse events in case of COVID situation. But in addition, it has selectively reduced the immune function. So it should be also screening. And if there is any adverse events, in that case, we have to stop it by active infection. And always consult with the physicians. You have to advise any adverse special situation like active hepatitis, tuberculosis, pregnancy. In certain situations, they have to consult with the physicians. And in COVID situation, IV infusion drugs like infliximab, it should be avoided because it has the more possibility to contact with COVID patients. So these are the few aspects we must advise or support the patient. Thank you.
Can I add something?
Yes,
Hello.
yes.
I just
Yes, Shamim, you go on.
From the patient and their caregivers just to report any sign of infection. That's it, and don't to use any live vaccines. These two advice I am giving to my patients.
So honor to our president. So I'm not feeling well because I had COVID. So I want to beg leave with all this. Shamim, thank you very much for a nice presentation.
Yes.
Thank you.
Thank you,
sir.
So the last question to anybody who would like to answer from the panelists or our speaker, what about the name psoriasis and biologics? Is it just last question about to comment? Anyone to like to answer from our panelists or the speaker?
Yeah, nail psoriasis, the secukinumab and adalimumab is very much effective in nail psoriasis.
Okay. Thank you all the participants for breaking the myths and the facts and all encouraging us to use biologics. Especially thanks Dr. Shamim to show the pathway and initiatives already our senior SARs are already using, and like Professor Kobi Choudhury sir and Rashid Mohammad Khan sir has clearly mentioned, even with COVID or with hepatitis or even previously treated chemotherapy or sarcoidosis, nothing should make us fearful to start using biologics. Okay, now especially from behalf of the Psoriasis Awareness Club, our Secretary General, Dr. Abu Hena, I will ask to say him something about today's session and about today's topics. Dr. Abu Hena, sir, are you there, sir?
No, Abu Hena sir is not available, madam.
So, okay, then as we have come towards the end of our session, I would like to have some vote of thanks from behalf of the Uniderma UniHealth. So again, first I would like to thank Unimed UniHealth, who has always stand by unconditionally by the dermatologists of Bangladesh. You have a separate wing dedicated team called Uniderma, which makes you stand out unique among all other pharmaceuticals. Thank you again, Uniderma, from behalf of your sponsor. Now I would ask Mr. Anisur Rahman, the marketing manager, to say a few words about vote of thanks. And thereafter, I would request Professor Dr. Samuel to conclude the session and summarize the session. Thank you. I'm signing off. Towards Mr. Anisur Rahman, Unimed UniHealth.
Thank you, madam. Am I audible? Can you hear me?
Yes.
Yes.
Thank you, Honorable Chairperson, respected doctors and my dear colleagues. Good evening. As you know, I'm Mohammad Anisur Rahman, working as a marketing manager at Uniderma. And you know, Uniderma is the concern of Unimed UniHealth Pharmaceuticals Limited, which is truly focused on dermatology. It is our great honor to participate in this webinar of Psoriasis Awareness Club. I, on behalf of Uniderma and Unimed UniHealth Pharmaceuticals Limited, would like to thank to Professor Dr. Muhammad Samuel Haq, President, and Dr. M. Abu Hena Choudhury, Secretary General of Psoriasis Awareness Club, for choosing us as a scientific partner of today's seminar. I'd like to thank to Dr. Sarkar Mahbooba Ahmed Shamim sir, Chief Consultant, Dhaka Dermatology Institute, for his excellent presentation on biologics in psoriasis treatment Bangladesh perspective. Special thanks to respected Professor M.U. Kobi Chaudhary sir, Professor Brigadier General Dr. Mohammad Abdul Latif Khan sir, Professor Rashid Mohammad Khan sir, who has enriched the total session as panel of experts. And special thanks to Dr. Yasmin Jordan madam, who is also the scientific secretary, and thanks for facilitating the program in excellent way. Lastly, I'd like to thanks to all doctors, my colleagues, for participating in the program, and look forward to see you all again in another program, and wish you good night. Thank you, sir. Thank you, madam.
Okay, we'll now conclude this session. Before concluding this session, I want to thanks to all the participants who has taken so many difficulties to come and join this session. Thank you very much to all, and thank you to all the panelists, and thank you to the speakers who has give his lecture so informatively and so nicely. Thank you all. And I think we have already covered why we want this biologics drugs to be introduced in our psoriasis patient. We have covered what is the hesitation we will feel to use the biologics, what are the contraindication to use, why we have to stop the medication, when we have to continue the medication. Every aspect I think we have covered, and I think it is a unique session we have arranged, and with a very nice and expert panelists and speakers. Thank you all. Lastly, I must thanks to the Unimed UniHealth Authority, who has kindly sponsored this program. And nevertheless, I must say thanks to my scientific secretary, Dr. Joardar, to arrange this program. Moderator, and thank you all, and wishing we can arrange another session in coming month or next with another hot topics of psoriasis. Thank you. Lastly, we have to say that we need counseling to the patient. We have to counsel the patient. This is the duty of the dermatologist. And if the patient is happy to use these biologics, I think we can bring these biologics to our country like Western world. And that will give the beautiful and good quality of life of the psoriasis patient. Thank you all for attending. Thank you very much.
Thank you very much, and good night.